Okay. Good afternoon, everyone. I'm Allison. I'm really delighted to introduce my colleague, Dr. Chantel Martin, who is an assistant professor of epidemiology and social epidemiology program member. In addition to her appointment in epidemiology at UNC, Dr. Martin is also a Carolina Population Center Fellow and is co-leading the Cardiopulmonary Disease Translational Research Focus Area in the Center for Environmental Health Studies at UNC. Dr. Martin's research uncovers the social and biological pathways by which stressors during critical periods of development affect health across the life course. Her impactful and timely research examines the impact of neighborhood crime, deprivation, segregation, and air pollution on biological markers such as epigenetic alterations related to aging and cardiometabolic health outcomes. Her research on these topics aims to improve health and ameliorate health disparities among racial and ethnic minorities across the life course. In recognition of her outstanding scholarship, Dr. Martin has received numerous prestigious awards and honors over her academic career. She currently holds a highly competitive NIH Pathway to Independence Award that focuses on individual and neighborhood level stressors and how these exposures influence epigenetic alterations beginning in childhood. And fitting with the themes of the CPC, Dr. Martin's research is very interdisciplinary and methodologically rich, drawing from social sciences, environmental sciences, reproductive health, cardiovascular health, and genomics, just to name some. There's other areas that she also touches upon. I have truly enjoyed the opportunity myself to collaborate with Dr. Martin over the years. So it is a real honor today to introduce her presentation. And without further ado, let us welcome Dr. Chantel Martin.
Thank you, Allison, for that amazing introduction. And thank you to the folks behind the scenes working to make these seminars virtually possible. I'm very happy we were able to reschedule this talk from last spring because, I've been doing a lot of research over the last couple of years, really looking at embodying place and how that relates neighborhoods and health disparities. And I think, as Allison mentioned, this work could never be more timely. And so I'm really excited to be able to present this work that I've been doing in collaboration with my research group and the many collaborators across UNC and at other institutions. And so I'm going to start by providing some background and context around my research and what motivates this line of research, and then follow with two examples of studies that are ongoing that relate neighborhoods and health, and then wrap with some future directions briefly where we see this work going. So structural racism is a pervasive issue in this country and is really one of the primary drivers of health inequalities. I think this paper recently published in The Lancet by Zinzi Bailey et al. Really did a great job of describing and detailing structural racism and its linkages to the health inequalities that we see today. I just want to read here this definition that they provided for structural racism, which is that it involves the interconnected institutions whose linkages are historically rooted and culturally reinforced. It refers to the totality of ways in which societies foster racial discrimination through mutually reinforcing inequitable systems in housing, education, employment, earnings, benefits, credit, media, healthcare, criminal justice, and so on, that in turn reinforce discriminatory beliefs, values, and distribution of resources, which together affect the risk of adverse health outcomes. And so my work explores one example of structural racism, which is ongoing residential segregation. This has had long-lasting implications for health in this country, and as David Williams and Chiquita Collins wrote in 2001, it is a fundamental cause of racial disparities in health. Residential segregation was also extensively discussed in Richard Rossing's book, The Color of Law, which I think was presented to me or introduced to me during a CPC seminar. And it sums up racial discrimination, which was enacted to keep specific groups, particularly Black and other minority groups, from living in neighborhoods with white people. These policies were passed by federal, state, and local governments to keep residential segregation in place, one of which we know is redlining, which is a color system used to grade neighborhoods based predominantly on the presence of minority groups. And so here I show a redlining map of actually Durham, North Carolina, and the maps that the color codedness of the maps were actually used to guide lending practices. So neighborhoods that were colored red were given a hazardous grade and characterized by undesirable populations or an infiltration of it. And mortgage lenders would refuse to make any loans on properties in these neighborhoods. And as Williams and Collins says, efforts to eliminate racial disparities must seriously confront segregation and its pervasive consequences. Here, I'm sure many of you have seen or read things such as zip code determines your health. However, I want to point out that it's not the zip code or even the census tract or census block that determines your health, but instead the structural consequences of residential segregation. Dr. Glass coined the phrase ZNA to really emphasize the impact of place on health as opposed to your DNA. Here's just an example that I pulled from California showing a 15-year life expectancy difference for a child born in Stockton, California, which is the zip code 95219, and a child born in, I think, Newport Beach or Orange County, California, with the 92657 zip code. And while these two areas are 5 hours away, we don't have to see large distances between places to see such stark differences in life expectancy. As you see here on the right, this is from data that's right here in our backyard in Durham. And I pulled this from the Durham Neighborhood Compass, which has done a great job of collecting important data at the census tract and block group levels. And here I'm showing just two census block groups in Durham. This is the downtown area up here at the top, tract 9, block group 2, and the University Road area, Forest Hill area. And we see here there's a 10-year difference in average age at death. And what's more explicit is the neighborhood income disparities, which is nearly $50,000. And so these are some of the long-term consequences of residential segregation right here in our backyard in Durham. And residential segregation doesn't just shape where people live, it also impacts their educational employment opportunities, healthcare access, environmental exposures and toxins, policing and crime exposure, as well as access to healthy foods and recreational facilities, parks, and green space. And consequently, all of these work together, and this interconnectedness of all of these drive the health inequalities that we see today. And it also impacts residential mobility. This is some work that I pulled from Patrick Sharkey, looking at the residential mobility across generations, or within and across generations. And I'm showing a figure here with, I think this is from the PSID, Panel Study of Income Dynamics, where we're looking at mobility patterns among Black and white children born from a 15-year period, 1955 to 1970, and then again, those born 1985 to 2000. And so what we see is that children that were born in 1955 to 1970, 62% of Black children grew up in neighborhoods with at least 20% poverty, compared to only 4% of white children. Looking at the other end of the spectrum, only about 10% of Black children grew up in neighborhoods with low poverty or less than 10% poverty, compared to 74% of white children. And then you fast forward this to the children that were born between 1985 and 2000, little has changed. Still only 10% of Black children grew up in neighborhoods with low poverty. So we can see that this doesn't just impact the generation that's born within these communities with neighborhood disadvantage and poverty, but also across multiple generations. And so when thinking about this and how these neighborhoods impact health, I turn to Nancy Krieger's book, epidemiology and the people's health. And there's a chapter in this book about embodiment and how people literally embody biologically their lived experience in societal and ecological context, thereby creating population patterns of health and disease. And she goes on to talk about these multiple pathways of embodiment, including social and economic deprivation, exogenous hazards, social trauma, targeted marketing, inadequate, degrading healthcare, and the degradation of ecosystems. So this was really helpful in trying to conceptualize how neighborhood environments actually might be related to health and what these potential mechanisms are. And so I took this framework that she provided and kind of extended it to reflect my own work and thinking about these pathways of embodiment at the neighborhood level. So the social and economic deprivation, so there's income, education, housing, neighborhoods, environmental hazards and toxins, traumatic stress, racism, discrimination, adverse childhood experiences and immigration stress, targeted marketing of unhealthy health behaviors and the inadequate access to quality healthcare services. And these can have biopsychosocial responses. So there's psychological, inflammatory, and epigenetic pathways that are involved that can then go on to shape cardiometabolic outcomes, cardiovascular dysregulation, metabolic disorders, and chronic inflammation. And then incorporating the life course frameworks also helps me to think more critically about sensitive periods of development or windows of susceptibility when individuals may be more vulnerable to these pathways of embodiment. And so this has all helped to help me kind of refine my overall research goal for this line of work that I do. And so I'm trying to answer the question of how does the neighborhood context influence and transmit health disparities across the life course. And so I'll be presenting two studies here, one of which was, as Allison mentioned, was funded by NIMHD through Pathways to Independence, or K99R00, really focused on the epigenetic mechanisms of these prenatal environmental stressors and offspring health disparities. The results that I'm going to present today is from one particular study that has been led by an amazing doctoral student in epidemiology, Evans Lodge, looking at prenatal exposure to neighborhood crime and offspring health. And so what we were interested in thinking about how neighborhood crime during this critical period of pregnancy would impact the offspring health and the mother's health as well, we started to really conceptualize and think about the measurement of crime, because we know that neighborhood crime is associated with higher perceived stress and poor physical and mental health. Police reported crime data, which I will refer to as sometimes just crime, is commonly used as a measure of psychosocial stress and exposure to crime in population research. However, what we know is that crime is unequally distributed across racial and ethnic communities. There are additional methodological concerns when using police reported crime data that we encountered. First, data are often aggregated at administrative neighborhood levels, including census tracts, census block groups, and other area level residential units to generate these crime counts and rates for research. Studies also utilize these residential buffers to capture crime within a set distance of a participant's home. And what we quickly learned when doing our literature review is that this is not uniform across studies or disciplines. So it makes it a little difficult to really replicate studies as well as compare across studies. There was also the issue of potential measurement error due to non-overlapping geographic boundaries. For instance, when neighborhood boundaries extend beyond the crime reporting area, and this boundary effect essentially becomes a missing data problem. And so how do we overcome this in our analyses? Also, for studies with short windows, such as the pregnancy period, seasonality concerns become even more of an issue, and thinking about ways to address this in our studies. And lastly, even if we had complete data for police reported crime, with 100% sensitivity, we must also understand that police reported crime is not solely a measure of criminal activity, but due to pervasive over-policing of neighborhoods with large Black, Latinx, and other racialized populations, these data inherently represent some combination of both exposure to crime and exposure to police, and this entangled exposure varies by neighborhood composition. As an example, we know Black people are disproportionately exposed to punitive policing and police violence due to policies that's dating back to the 70s and 80s, the war on drugs. So we know this, and how do we address this and overcome this in our data with these police reported crime data that's available, publicly available often to us to use in our research. And so our research group was interested in estimating these data in relation to health, and how do we actually create crime categories or actually even measure crime when we know that there are these methodological challenges at hand. And so using data from the Newborn Epigenetic Study, or NEST, we wanted to try to look into this. And NEST is a prospective birth cohort study with follow-up of offspring into early childhood and adolescence. Women were recruited from prenatal clinics at Duke University Hospital and Durham Regional Hospital obstetrics. There were about 2,700 pregnant women that were recruited. They were over the age of 18 years of age or older, and they were recruited between 6 and 42 weeks of gestation, with a median of 30 weeks of gestation. We have more than 1,100, right at 1,100 participants who self-identified as Black, Latinx, or white, and lived within the Durham city limits. And I'll go over why we had to limit it to the Durham city limits in, I think, the next slide, that were utilized in this analysis. So when thinking about neighborhood crime, I reached out to the Durham Police Department to see if we could, if they had data available for us to use for this study. And they quickly sent us over an Excel spreadsheet of police reported crime from April 1st, 2006 through December 31st, 2012. This data included the date, description, and donut mask GPS coordinates. This is used to protect against reverse geocoding and to ensure anonymity of participants. The NEST participants' addresses were geocoded and linked to the crime data. And we created the 3 categories of crime: violent crime, drug and alcohol, and burglary exposures. And you can see here to the right the distribution of the total reported crimes that span this period. And this is the April 1st, 2006 through December 31st is a study period for the NEST cohort as well. So it overlapped nicely with the period of NEST. So violent crime represented about 13% of crimes, drug and alcohol crime was about 6%, and burglary was 14%. And then other crimes was about 66%. But we were only focusing on these violent crime, drug, alcohol crime, and burglary. So to create categories of crime and overcome some of the issues I mentioned earlier, we first counted the reported crimes for each type within 800 meters or a half a mile of the participant's residence for their gestational window. So this was from the last menstrual period to the date of delivery. So we captured crime exposure for each participant during their pregnancy period. But what about participants who live within 800 meters of the Durham city limits? Because we only had crime data for Durham, but we know that people live on the boundaries of the city limits, so these boundary effects. What we did to try to overcome this was divide each participant's 800 meter crime count by the area of their 800 meter buffer within the city limits. I have on the next slide, I'll kind of, illustrate what I'm talking about here. We also wanted to capture crime density within the population. So we created these measures of crimes per 1,000 people per kilometer squared. And so we had both these area level measures of crime with the 800 meter residential buffers, as well as this block group crime, because block groups are often used as in the literature as well. So we created both to be able to compare our results to the existing literature. And this is a nice illustration of what I mean by trying to overcome these boundary effects. Here you see this dot here representing the participant's residential address. The circle around the home is the 800-meter buffer that we created. The black square is the Durham city limits. And so generally these red dots, we only have information on crime that are within the city limits. So this information so this area outside of the Durham city limits that is also within the participant's 800-meter buffer is missing information. And so this is what we were trying to overcome by dividing the 800-meter buffer by the area that's within that, the area that's within the 800-meter buffer. And so these are some of the results that I'm going to get into. This is the density of crime within the study period in Durham. And what we see here is crime generally clusters, or reported crime generally clusters within the Durham city limits. If anyone's familiar with Durham, this is the city center. So crime generally clusters within the city center. Sorry if I said limits. With higher concentrations of drug, alcohol-related crime reports in the city center, and then burglaries were least concentrated, and as you can see, more dispersed among Durham. And so there is a little difference in the spatial distribution of these crime categories within Durham. As I mentioned, there's the issue of seasonality, or the when crime actually spikes in Durham. And so we wanted to look at the seasonal variation, and we see in panel A, this is the seasonal variation in total crime. So adding up all of the crimes that occurred in Durham during the 2006 to 2012 study period. And we see peaks in the summer months and lows in the winter. And this is consistent with criminology and public health literature. And the three crime variables we used in our study followed similar seasonal patterns with a little less obvious peaks and lows. But we do see evidence of the seasonality of reported crime. So when you're thinking about a pregnancy, which may not span over all of the seasons of the year, we need to account for that in our analyses. And particularly thinking about women who deliver, which is very important for health inequalities data, women who deliver preterm birth and very preterm, which is higher in Black and racialized minority groups. And so this is one of the things that we also wanted to account for in our analyses. So these are some nice volcano plots that we generated to illustrate the frequency of each type of crime within the 800 meters of participant residence in panel A. And this is, panel B is the crime per 1,000 people per kilometer squared. So the density of crime that is occurring in within people's area or buffer. And what we can see from these volcano plots is that crime is strongly patterned by participants' race and ethnicity, with self-identified Latinx mothers having higher exposure to area level crime than white mothers across each type of crime and method of density estimation. So for instance, looking here at panel A in the violent crime, we see that, I think, let me look at my notes, a white mother was exposed to only 3 to 4 violent crimes per kilometer square within her 800 meter buffer of residence during pregnancy, whereas a Latinx mother was exposed to 24 violent crimes and a Black mother was exposed to 19 violent crimes during pregnancy. And when adjusting for population density, which is in the bottom panel, the disparity lessens a little. However, we still do see disparities in crime across the 3 categories. The disparities in drug and alcohol related crime in panel B, these are actually a little bit even larger, more exaggerated, while reported burglary within the 800 meters of the participant residence showed least variation by race and ethnicity. we did actually look at the crime counts uncorrected for boundary effects, and the disparities were exaggerated. And this is relatively because white mothers are more likely to live within areas that extend beyond the city limits. So what does this all really mean? I think one of the things is the model stratification, first of all, revealed these pronounced disparities in neighborhood crime exposure, with Black and Latinx residents of Durham exposed to systematically higher police reported crime than white residents. This would not have been uncovered in the absence of these stratified models, which has important implications for researchers who are using these types of data and modeling the effect of crime exposure on health while including terms for race and ethnicity in their models, because they will be smoothing over data that essentially does not exist. For example, white residents with very high police reported neighborhood crime. This also adds the question of what are these crime data? While police reported crime may be statistically correlated with true crime rates, it is also by definition highly correlated with police presence in a neighborhood or area. So we have to consider what these data represent. For Black and Latinx residents, police reported crime data reflects exposure to crime and exposure to police in the neighborhood, both bringing with them the potential for stress, violence, and even death. And this isn't necessarily the case for white residents. And as a result, these are fundamentally non-comparable exposures. So we have to be critical in thinking about this when we are using these types of data. Secondly, we demonstrate that there are two methods to measure, crime exposure within 800 meters per kilometer squared of residents, and crime density per 1,000 people per kilometer square. Both of these seek to overcome the effects of the non-overlapping boundaries of crime data. This is not something that we've seen commonly in the literature. And this is important because we found that when these edge effects were not accounted for, the disparities were inflated. The decision as to which of the two crime measures, the crimes within the area or the density within the area to use, one would want to think about the hypothesized mechanisms through which reported exposure is expected to impact health, while keeping in mind that neighborhood, racial, and ethnic composition will modify these effects based on experiences of police violence. And lastly, seasonal variation in crime. In studies of short duration, such as the gestational period, we have to consider the effects of season on our results. And what we have decided to do with ours, and these are some of the crude and adjusted results of the neighborhood crime on offspring blood pressure in the first 48 months, is including a variable to account for the season of the child's birth, or I think we used actually month of birth in this analysis. So we would want to maybe include a variable for seasonality in our models. So here I'm going to present some work that's in preparation that looks at, like I said, neighborhood exposure. This is actually looking at, in panel A, children of Black women, panel B, children of Hispanic women, and panel C, children of white women. The straight lines estimates, these are within the 800 meter buffer, but we also provided this within the block group buffer, the block groups, as well as a comparison, which are the dashed estimates or dashed confidence interval lines. We have we're showing here violent crime, drug and alcohol, as well as the combination of violent and drug and alcohol. And we see here in panel A that there is a positive association, or evidence of a positive association, between neighborhood crime exposure during gestation and blood pressure, systolic blood pressure percentile and diastolic blood pressure percentile for children of Black women across each type of crime. But we don't see that in the children of white women, as well as children of Hispanic women. The confidence intervals are rather large for the children of white women. This is because we didn't have as many white women in this study. we do see if you, in the adjusted models, there is some attenuation of the results, but we do still see this effect. And so now I'm going to turn to some newer work that we've been doing in the social epigenetics working group that I've been fortunate to lead and continue to work with. This is focusing on another piece of the pathways of embodiment and how neighborhood quality can become embodied through epigenetics or epigenetic aging. And we've done this through a cross-sectional study using data from the Detroit Neighborhood Health Study. And I wish I could spend a little bit more time talking about epigenetics and DNA methylation, but I will do a plug here for those that are interested in more details. There is an epigenetics workshop that will be held next month that's sponsored by the Biosocial Training Program here at CPC, that's hosted by my colleague, Kaven Ward-Cavanis, whose work I actually will present briefly in a bit. But DNA methylation alters gene expression without changing the underlying DNA sequence. It is the most commonly used, commonly studied epigenetic measure, and occurs when a methyl group is found at a CPG site or a cytosine guanine dinucleotide site. It's affected by underlying genetics, lifestyle choices such as diet and smoking, as well as environmental exposures. And recent DNA methylation array technology has presented a unique opportunity for researchers to derive these biomarkers to track changes in biological processes such as aging and health risks. Over the last decade, we've seen this boom in machine learning techniques to help generate these epigenetic biomarkers that correlate with chronological age and mortality. And actually here show just a few of the many. I feel like there's new ones that develop pretty quickly. So it's hard, we try to keep up, but it gets a little tedious keeping up with the number of clocks that are developed. But here I'm just focusing on the 4 that our lab has been using to look at the impacts on neighborhood quality and epigenetic aging. And that's Hannum's age acceleration, which was developed by Hannum. It was one of the first measures generated from DNA methylation. It was collected from whole blood, so it's a single tissue DNA methylation age estimator. And that estimator included 71 CPG sites that were found to be associated with chronological age. Then Horvath's age acceleration, also known as Horvath's clock, came along, which is also one of the more widely used epigenetic clocks that we see, and it's a multi-tissue DNA methylation age estimator. I think when we're looking at epigenetic aging, between Horvath and Hannum's clocks, we see these most oftenly used, and a lot of that has to do with them being around the longest. But Horvath's clock, or Horvath's age acceleration, was tested in many cell types and tissues, I believe over 50, and this generated 353 CPG sites that correlate with chronological age. And more recently, Levine's phenotypic age acceleration, or pheno-age, is a newer measure that is specific to whole blood and measures aging related to more than just chronological age, but also clinical phenotypes to try to get at dysregulation of systems and organs. So it includes chronological age, as well as creatinine, glucose, C-reactive protein, albumin, red cell distribution, and some other measures. And so this resulted in 513 CPG sites that are used to approximate pheno-age. And then also there's an epigenetic mortality risk score that we've been using. This is a validated blood-based mortality predictor created from a weighted sum of 10 mortality-associated CPG sites. So these 10 CPG sites are related to all-cause mortality, but also cancer and CVD-related mortalities as well. And when calculating epigenetic age acceleration, you're looking at the difference between DNA methylation age based on the calculator or estimator that you're using and chronological age. When DNA methylation is greater than or outpaces chronological age, this is considered positive age acceleration, or that your methylation age is older than your chronological age. And if DNA methylation age is younger or less than your chronological age, this is considered negative age acceleration, or DNA methylation deceleration, age deceleration. And we see here to the right, age acceleration is related to a host of age-related conditions, including Alzheimer's, cognitive decline, dementia, mortality, insulin levels. Pretty much all of the systems in the body are impacted by this. And so, like I said, we were interested in trying to understand how or if neighborhood quality was associated with these epigenetic biomarkers of aging. And to do so, we used data from the Detroit Neighborhood Health Study, or DNHS, which is a prospective representative longitudinal cohort study of predominantly Black adults living in Detroit, Michigan. We had about 158 participants with both neighborhood context and DNA methylation samples that were assessed at baseline that we utilized for these analyses. Neighborhood quality was assessed in 3 different ways. We had actual 19 quality measures that were assessed by trained evaluators who actually went out to these neighborhoods and checked off the presence of or absence of the conditions of streets, non-art graffiti, tobacco advertising. They looked at if there were for rent or lease signs, people on the streets, green space such as trees and gardens, and a whole host of other things. Because we had limited sample size, 158, as I mentioned, we wanted to retain power, so we decided to examine these principal components, or use principal component analysis to decompose these 19 measures. And we decided our priority to retain factors with that explain more than 90% of the variance. We also had data from the American Community Survey, 2008 to 2013, which overlaps with this baseline period. And we use neighborhood poverty, which is the percent living below the poverty level. And we also had, which was nice, the perceptions, individual perceptions of the neighborhood, and their perceptions of social cohesion. So these 5 questions here were assessed: close-knit, unified neighborhood, willingness to help, get along, share same values, and their neighbors can be trusted. These were measured on a 5-point Likert scale, with higher scores indicating greater neighborhood social cohesion. And so now I'm going to present some of findings from a paper that is almost ready to go out and be submitted. And here's the first neighborhood poverty and epigenetic age acceleration. The models I'm presenting in the next 3 slides have been adjusted for race, ethnicity, education level, employment status, smoking, alcohol intake, and years living in the neighborhood. And what we can see, I have this broken up, looking at this for the total sample, which are the square estimates. The triangles represent women, and the circles represent men, because we do show there is evidence to say that neighborhood quality or neighborhood environment and epigenetic aging associations do differ, or even not just epigenetic aging, but also biological aging. So telomeres, these associations do differ by gender. So we also were interested in looking at differences in gender. And so we did find some evidence of positive association where higher neighborhood poverty is associated with age acceleration, particularly in pheno age, where we see the effect estimates, although the confidence interval does cross the line, cross the null value a little bit, the estimate for female or for women does show this positive association. So the effect of neighborhood poverty on age acceleration, this positive association seems to be primarily driven by women, particularly in this pheno age. And so then turning to neighborhood social cohesion, interestingly, we found a different effect. We saw that there seems to be a negative effect, or neighborhood social cohesion being associated with negative age acceleration or age deceleration, so that higher neighborhood social cohesion among men, we see that higher neighborhood social cohesion is associated with epigenetic age deceleration, as evidenced by the, particularly in pheno age and the Hannum age. And so taking these two together, I was interested in seeing how does neighborhood social cohesion, so this positive aspect of the neighborhood, does it modify the impact of neighborhood poverty on age acceleration? Unfortunately, because we only had 158 participants in this analysis, we weren't able to do any higher order tests to look at a three-way interaction between poverty, cohesion, and gender. But we did look at this in the total sample. So now the squares are the associations in the total sample, triangles those among high social cohesion that reported having high social cohesion, and the circles those that report having low social cohesion. And our results were suggestive of difference in the neighborhood poverty age acceleration association, particularly in the Horvath's age, where we see that individuals living in neighborhoods with lower social cohesion experience age acceleration, or Horvath age acceleration, while there appeared to be no association among individuals living in neighborhoods with higher neighborhood social cohesion. So there seemed to be some evidence here that the positive aspects of the neighborhood does have a buffering effect on the poverty epigenetic aging association. And this is a paper that was published this year by Dr. Cavan Ward. Cavan is using these same data, looking at neighborhood quality principal components that I mentioned earlier, and the epigenetic mortality risk scores. And if we see here at PC7, which is defined by characterizations of abandoned cars, people on the street, non-art graffiti, and the streets being in poor condition, and a negative loading for alcohol advertising, we see similar gender effects between PC7, which was characterized by those positive loadings and negative loadings, and epigenetic mortality risk score. Specifically among women living in neighborhoods characterized by PC7 was associated with epigenetic mortality risk score, which was really interesting to see, and kind of confirm some of the results that we also found in the neighborhood quality and the pheno age study, that neighborhood poverty and pheno age acceleration. And also similarly, this study examined protective effects of positive neighborhood features, green space, and found evidence that there seemed to be that the positive epigenetic mortality risk score association was only among those living in neighborhoods with little to no trees and gardens. However, the association was not present for those living in neighborhoods with trees and gardens. And so we do see that there are these positive aspects of neighborhoods that could potentially be buffering or adding a protective effect for individuals in relation to epigenetic aging. And so the combined efforts of this work demonstrates evidence that poor neighborhood quality may adversely impact epigenetic aging. However, this could be buffered by, like I said, the positive aspects of the neighborhood, with the social cohesion and the green space that we found in our studies. These aspects may provide protective effects. And I think this is very important because as researchers, we often examine neighborhoods from a lens of deprivation. And this work kind of speaks to the importance of those positive fabrics within neighborhoods that exist that could provide some protection and need to be further evaluated. And it's also possible that mechanisms may differ by gender. Research exists that shows women respond and are impacted differently than men in respects to their neighborhood context. And our findings provide some additional evidence of these differences, which needs to be interrogated more in studies with larger sample sizes. And so to just provide a look ahead of where I'd like to see this work going and some ongoing work we're doing in the research lab. With the newborn epigenetic study, or the NEST study, we have not just data for neighborhood crime, but also neighborhood poverty. We have air pollution. We're developing measures for residential segregation. And we're going to look at the independent and joint impacts of prenatal environmental stressors on DNA methylation and offspring cardiometabolic health disparities. In a separate study, we'll be looking at early and life course social stressors and adult DNA methylation and health disparities. I'm also very interested in longitudinal DNA methylation patterns and how these change as exposures change. And lastly, I'm interested in, as you could see from the study in NEST looking at neighborhood crime exposure, I've become very interested because of this uneven distribution of neighborhood crime by ethno-racial composition. How do we measure or get at the intricacies of crime and policing? And are there other data out there that we could use to really try to disentangle this? So I'm really interested in the measurement of neighborhood context, but also how do we model these? Because they, with neighborhood poverty, neighborhood crime, air pollution, these are all tend to be highly correlated and pose methodological challenges. So also, how do we model these social exposures? So in sum, I have a growing research agenda with tons of data and unlimited possibilities and infinite collaboration opportunities. So if anyone's interested, please reach out to me, because I'd love to collaborate more. I just have to acknowledge my amazing collaborators that I've been so fortunate to work with, including folks who are CPC fellows, as well as those outside of my very own discipline. I'm very excited to be collaborating with folks in geography and public policy and criminology, which has really enriched my research, and I think taking it to another level, as well as the amazing students that have really been who's driving this research agenda forward. The study participants and the study teams that have provided countless hours to allow us to research these questions, and the many funding sources that have supported this work. And so I would be remiss in doing this work and not saying the name of Breonna Taylor and bringing attention to the many other countless acts of violence against Black and brown people in this country at the hands of police, at the hands of structural racism. This is why I do the work that I do. And beyond the police murders, but the current pandemic, which is disproportionately impacting Black, Latinx, and Indigenous people, now more than ever, we must recognize racism as a public health crisis, and anyone in population science and public health research interested in health equity must center this and do the work to dismantle systemic and structural racism in order to eliminate health disparities. Thank you, and I'll now open it up for questions.
Thank you, Chantel, for the fantastic presentation. I see we have a question in the chat, and the question is from Dr. Robert Hummer, and he said, fascinating presentation, Chantel, across both the Durham and Detroit studies. Thank you. My question has to do with the Detroit analysis on epigenetic aging. You mentioned including a lot of controls, race, ethnicity, employment status, et cetera. When examining the relationship between neighborhoods and aging, is it possible you're over-controlling? Likewise, what might the more reduced form association look like?
Yes, that is a great question, Bob. So if you notice, we did include factors that would probably be on the pathway from neighborhood environment to epigenetic aging. So things like alcohol use, cigarette smoking, that are probably I would say bringing those associations closer to the null, so attenuating the associations a little bit. So if you look at, I didn't present the crude results, but if we looked at these associations, not adjusting for anything, of course, we would see much larger effect estimates of more reduced set of covariates would, we have a hard time. I think some of the variables that we would include, education, so socioeconomic variables, SES, things that we think would explain select or reasons that people might live in certain neighborhoods. But we often go back and forth with that even. So if I had to think about a reduced set of controls in an analysis, it would be things like socioeconomic status, race, ethnicity, but the behaviors or actually also include time living in the neighborhood. I would include that in the reduced set. But things that like behaviors or health related risk factors that we know could be as a result of living in the neighborhoods that impact epigenetics, I probably would not include those. So you're right, you did pick up on something very important there with, we were including things that might be on the pathway.
Okay, great. There's another question from Eileen Spicer. It says, great talk. I learned some new things, which is always fun. I am curious to know how you are thinking of using the ad health data to move this research agenda along. I know that there is good biomarker data, but what kind of place-based data does it offer you, and what outcomes are you thinking about? Just curious.
Yes, thank you for that question. I'm very excited about ad health data to continue this research agenda forward. I'm a co-investigator on a recently funded, actually, I don't have a good concept of time, I think we're in year 3 now, but a study of social epigenetics where we are now getting data on adult DNA methylation at wave 5. And so I'm really excited about this because it will allow for a true life course perspective, or these life course stressors, and really look at disentangling early life stress from later life stress and how that relates to DNA methylation patterns, as well as how these DNA methylation patterns that are related to life course stressors impact or are linked to health disparities, particularly in wave 5 cardiometabolic outcomes. So I'm planning to look at things like cardiovascular disease, cognitive outcomes, mental health outcomes. So there's a lot of questions that can be answered with the rich data of ad health and having DNA methylation in adulthood with these life course stressors, and really starting to disentangle the duration of exposure, the timing of exposure, and how that relates to DNA methylation.
Thanks. And there's another question from Doug Lowen. And it says, thank you for this inspiring talk. I learned a lot. 2 questions. 1, could you talk about the pros and cons of epigenetic aging markers versus a health problem scale? And can you talk about how you would model cumulative exposure to neighborhood quality on health?
Yes. I missed the first question, Allison. Can you repeat that one?
Sure. So could you talk about the pros and cons of epigenetic aging markers versus a health problems scale? So I think that's maybe a health problem scaled from a survey, not exactly sure. And then the second part was, can you talk about how you would model the cumulative exposure to neighborhood quality and health?
Yes. Okay. Thank you for repeating that. So the pros and cons of epigenetics from a health survey, population health survey scale, if I'm interpreting that question correctly. Epigenetic aging is difficult to ascertain, for one. When we think about these large surveys, epigenetic aging requires samples, DNA methylation or DNA samples. B, requires these algorithms and machine learning techniques to develop these aging biomarkers. So I think that does pose a challenge when we're thinking about health surveys and really measuring epigenetic aging. But I think also from a health standpoint, I think an advantage of epigenetic aging biomarkers is that it can get at something beyond what we know of chronological age or actual health outcomes. So it could potentially tell us something that, or warn us of something that we might be able to prevent, because we do know that epigenetics are, can change due to exposures or lifestyle interventions and things of that nature. So I think it can give us some information that could be useful in describing populations or predicting health risk, or even being a biomarker of health. So I think there's a lot of research out now looking at can these be applied to other, not just aging, but other health outcomes. And so I think to be used as predictive measures. So I think that is something that is a bit of an advantage, but also the disadvantage of having to collect these data. How to measure cumulative neighborhood quality. So, excuse me. I have a paper that looked at neighborhood disadvantage across the life course in Ad Health. I think Ad Health is one of the few studies at a population level studies that allow us to conceptualize or utilize multiple stages across the lifespan to see how moving in and out of neighborhoods might impact epigenetics or even health outcomes. And so how would I measure cumulative? I think first we would have to figure out, how do we measure neighborhood quality? There's so many different ways to measure neighborhood quality. We have a paper right now looking at neighborhood disadvantage, and I think Patrick Sharkey's work in looking at like this 20% cut point that has been utilized in other studies and been carried forward in other studies as a cut point for living in neighborhood disadvantage, but also kind of thinking about the more severe levels of disadvantage, or things that are relevant to the outcome. So is it these comprehensive measures of disadvantage, or is it something like neighborhood education that is important? But back to the cumulative. So how long are you living in this? Across the life stage, did you move in and out of neighborhood deprivation or disadvantage, or was it persistent across the life course? And not just how long did you live in these adverse neighborhoods, but if you were able to move out of these neighborhoods, which we know is different by race and ethnicity, at what time point did you move out? So is it that you moved in adolescence, and did that change your health outcome, or did you move in adulthood and that have a different health outcome? So I think there's a lot of ways that we could think about cumulative neighborhood quality across the life course. And I think one of the studies, Ad Health, provides a good opportunity. And also when we think about neighborhood quality too, there's also like the food environment that's important to think about as well, and the many different aspects of neighborhoods that's important to consider. Thank you for that question.
Okay, looks there's a it's from Vic Schoenbach. More of a statement talking about the your examination of buffering by social cohesion scores. He says, it reminds me that we're coming up on the 45th anniversary of what Bart Kaplan used to refer to as a John Castle's valedictory address, his 1976 Wade Hampton Frost lecture on the contribution of the social environment to host resistance, in which he discussed the buffering hypothesis, and that UNC was a significant contributor to that concept and provided the site. And so we don't have much time left here, but I wonder, kind of building on that, to what your thoughts are about social support as a buffering mechanism, and if there are, perhaps critical periods in which social support could provide buffering, especially for some of these biological markers like epigenetic changes that might be occurring across the life course.
Oh yeah, yes. I do think that things such as social support and social cohesion are very important. for health and for buffering potential adverse health outcomes or adverse experience in neighborhoods and health outcomes. I'll speak scientifically and then anecdotally. So scientifically, we know that we see studies in early life, particularly which started in animal models, and we've also started to see them in human studies of parenting styles and nurturing and things of that nature, and how that shapes early life health outcomes. And I think we need to do more work in that of how do we define nurturing across the life course? And is it nurturing in infancy, and then as children go on, is it, you know, peer networks and positive peer support, family environment, which I know a lot of folks at CPC are doing. But I haven't seen this work as much done in regards to epigenetic aging. There's researchers down at Georgia who have looked at supportive family environment and have found that this could, there is some evidence to suggest this does have a positive impact on epigenetic aging in adolescence. And so I do think there is something there in regards to how this having a positive impact on epigenetic aging. And then anecdotally, I'll say, when I think about neighborhoods and and it kind of goes back to this, as researchers, we look at neighborhoods through this lens of disadvantage or the racial composition of a neighborhood, and we see neighborhoods that have high proportions of Black and Hispanics. I just think of the grandmothers and the older aunties that are in the neighborhoods that are looking out for the children, and you know your neighbors, and you have this support of, if mom has to work over, there's a neighbor next door that you can send that can keep an eye out for your child or watch your child after school. And these aspects of, or positive fabrics of neighborhood, are often not captured. And I think we need to do a better job of capturing those, because I do think these could have important buffering effects.
Great, thank you, Chantel. It's really wonderful, impactful work. And thank you everyone for being here today for this CPC and Social Epi program lecture. Thank you.